This is the Schroth Boss Podcast, a show that helps parents of kids with scoliosis find clarity in their path navigating the scoliosis journey.
You are about to be spoiled. Dr. Katie Blanchard, Schroth Method physical therapist and coach, brings together physical therapists, spine surgeons, and parents to share and discuss tips and tricks for managing scoliosis.
Scoliosis is not easy, but don't worry, we've got your back.
My name is Katie Blanchard, Schroth Method physical therapist. Thank you so much for hopping on another episode of the Schroth Boss Podcast. Today, I'm excited for you all to meet Dr. Lauren Matteini. She is an orthopedic spine surgeon at Fox Valley Orthopedics here in the Chicagoland area. And I'm excited for her to be here. So welcome, Lauren.
Thank you so much for having me. I'm so excited.
You're welcome. So first and foremost, tell us a little bit about yourself and how you became, to be connected with the spine and how that interests you.
Well, stories start with an experience, right? So I am an orthopedic spine surgeon by training, and I went into orthopedics because I was in sports my whole life. My family was in sports, and so there was a lot of injuries that we encountered, and so I was pretty excited about being able to help out and have my own injuries myself, and so that's kind of how you end up, a lot of times doing what you end up doing is connections. I always wanted to be a doctor for the most part. I was a science nerd, like through and through, took every course I could, and so when I could figure out how the human body worked, it meant a lot to me. I dove headfirst into my anatomy lab, and I am just stoked about anatomy across the board. So you can see I'm wearing my spine t-shirt because I love anatomy. So as I got into my orthopedics residency, I didn't initially want to do spine surgery. I didn't really know what I would encounter there. And when I did, one of the first surgeries I did was a deformity on a teenager. And so I was able to really get hands-on experience with the anatomy of the spine and what corrections of those kind of deformities do for the children undergoing them, which would change their cosmetics, right? Change their view on themselves, how people view them, help with limiting pain if they have it. Certainly we make them taller, which is kind of fun in the end.
Oh, for sure.
And you know what?
I wish
for
you
sure.
could make me taller. I'm only 5'1". So whenever you want to give me 3 inches.
in good Scully corrections, we give a couple inches back, which is kind of fun. So, but spine was always something early on in my residency that I really took to, and I got good at, so which was really fun. And I chose a fellowship where I could do both adult and pediatrics, which is a little bit unusual. It's not as common. Most pediatric scoliosis surgeons do a pediatric fellowship alone, whereas I did a spine fellowship, but did peds all year long. And so I'm able to be trained in both adult and children.
Awesome.
So that's where I'm at.
Gotcha. Well, that's awesome that you get to see the whole spectrum of, younger kids, all the way up to your old grandmas and grandpas, which I'm sure,
Yes.
You get a little bit of everything, the kids can be pretty funny as well as the older people.
And they're all different, which
Yeah,
makes
for
it
sure.
interesting.
So what types of scoliosis do you usually see? Other than just, kids and adults? Is there something specific that comes to you?
So I now work at Fox Valley Orthopedics, which is well out in the community suburbs of Chicago. And so I've actually almost kind of toned down my practice since my fellowship, because a lot of the really subspecialized children who have neuromuscular scoliosis end up needing a really kind of substantial multidisciplinary team. So what I'm able to accomplish out in the suburbs is provide for families conservative and surgical treatment for the more idiopathic types of scoliosis. So a lot of my children are being braced right now, which is great. I'm going to be as conservative as I can. So I'm able to help treat the non-surgical scoliosis in particular in the suburbs, so those families can have access to someone without having to drive maybe an hour or an hour and a half away. And so I'm taking care of the idiopathic scoliosis, or the non kind of specialized scoliosis, or I mean, maybe the boring type, but I don't think it's boring. So, but I really pride myself on the fact that I'm able to provide these families access when they may not have that, being so far out from downtown Chicago.
Yeah, for sure. I mean, access is huge. There's so many families and kids and parents who travel hours and hours, just to see a specific spine surgeon or a Schroth therapist or things like that. So going into those communities that really need it and being the one person that, is accessible is really, really exciting for those types of communities for sure. So talking about scoliosis and, conservative treatment, a lot of families are scared when they're referred to a spine surgeon. They hear the word surgeon and it's a scary thing. They think automatically my kid is going to need surgery. So how do you ease the process a little bit, and just assure them that surgery isn't always a scary thing? It may be required, it does happen, but your goal is to make sure, if you can, to prevent a surgery. So what's your advice for those types of parents?
So the scoliosis aspect of my profession is probably one of the main areas where I get to be a nearly 100% non-operative specialist, and enjoy it. So I really think that, yes, I'm a spine surgeon and I love operating, don't get me wrong. But I find that most scoliosis patients, if we catch them early enough, don't need surgery, but they will require a specialist like myself in order to follow them and help them through either continued growth with treatments such as bracing and Schroth therapy, or after growth with Schroth and physical therapy, or on the rare occasion, a procedure. And so if we catch it early enough, and it's one of those cases where we can guide their growth, and that guided growth is generally in a brace and with therapy, then we can keep them from needing surgery. And that, in this case, will always be my goal. Now, it's very different than our adult patients, which is a whole different can of worms beyond the scope of this podcast, that's for sure. But in these children, while the parents are afraid of going to a spine surgeon, I totally get that. About 9.9 times out of 10, surgery is not even a conversation we'll have for a long time.
Yeah, which that's, really important, especially, when scoliosis is caught early on, that it is, a lifelong thing until, they're done growing or even a little bit past then. And it's about monitoring and stopping the progression. So, surgery is that end point of if the other things, don't work out so good. But there's a lot that can be done in that other gray area before then. So we're not just jumping right to surgery, which is really great when we're talking about kids and parents and their children.
Agreed.
Yeah,
Agreed.
So really, really awesome there. And so what's your opinion, on bracing? I love bracing as a Schroth PT. I think they, Schroth PT, physical therapy, and bracing go hand in hand. But a lot of parents don't want their kids to be in a brace too, because there's a lot of other like social factors that go into wearing a brace and things like that. So what's your opinion on bracing?
Well, bracing works. And so that's the hard opinion, because it's a fact. So if the child has a curve that needs a brace because there's still growth left, then bracing works. But that bracing is, and that's not an opinion, that's a fact. And the studies prove that if the child has a braceable curve with enough growth potential left, and they wear the brace, that's going to be the key thing, is compliance for both the patient, the child, and the family. Bracing is effective only and at minimum 12 consecutive hours. Now that's the kind of the key word too, is consecutive. So most of the time those children will get their 12 consecutive hours overnight. But there are some kids who are in pretty substantial growth spurts where we'll ask them to wear it to school as well and try to get a 16 to 18 consecutive hour of wear before their after school activities. And that does become a challenge, and compliance is a challenge, but there's no opinion for bracing because bracing works. That's a fact. We've proven that. But it does take a lot of effort with the family, compliance, and it requires that the curve is braceable. Not all of them are, and not all of them require it. And that's the decision factor that we go through in the office.
Yeah, and that was one of my other questions for you as well. What makes a specific curve braceable or non-braceable?
So in my practice, depending on age, and age becomes a pretty defining factor in this. Curves that are in the low 20s from an angle perspective, we measure that on x-ray. If they're in the low 20s and they have several years of growth left, then that's a braceable curve. If they are already at 40 or 50 degrees, then that is past the braceable aspect, unless, kind of depending on, again, the age, we may consider bracing the child before surgery to continue to keep the curvature low. There's a lot of gray area in the 30s, and that really depends on the age and the maturity of the child. So girls will continue to grow for 18 months after their first period. So that's kind of when their peak growth velocity is happening. So we'll want to make sure that we're asking them every visit if they've had their menses yet. I always ask them and the boys about their shoe sizes, because I find anecdotally that their feet grow first. So if they've got a shoe change coming, then they're going to go upwards in height too. And so we'll monitor that. But the boys will grow most of the time till about 16, girls until about 14. That's the average. So there are a lot of factors in that, but the angle and the age makes the curve decisions from a bracing perspective.
Gotcha. Awesome. Thank you so much for that. I know our listeners are always wondering about bracing and, if it's a yes go or a no go. So overall, it is research based and it's the best thing for, most kids who are in those ranges and that those things apply to them. But it doesn't make it easy. So we know that, the kids out there that do wear the braces, it takes a lot, and, you're working hard. The parents are working hard for that compliance. So, if your kid is compliant, they're doing a really great job. You should be really, really proud as a parent, because it does take a lot of hard work and dedication for sure.
Absolutely. And if your kid is braced, or we're recommending bracing, we're doing it for good reason, because we don't want that curve to progress. We don't want them to have surgery. We don't. None of us are happy about doing that. And, we really will only recommend that if it's truly necessary. So if we can get the curve early enough and we can be compliant, and it's a couple of years where it really is, dedication, it'll pay off in the end. That's the goal.
Yeah. So yeah, definitely finding and seeing scoliosis earlier on and catching it early is definitely key to starting the treatment process. So I think we are getting a little bit better at screening for scoliosis, whether that be in schools, coaches and parents looking out for it, a yearly physical at a primary doctor, those sorts of things. But I know I've talked to you a little bit before, and one of the things that you mentioned is that in the screening process, a lot of times there's one specific population of kids with scoliosis that we miss that in, and that's, kids who suffer from childhood obesity. So do you have any tips and tricks to looking for scoliosis in those types of kids, or if there's something that we can do other than tackling childhood obesity at the core to, help catch scoliosis in those types of kids?
Well, you nailed it, right? So tackling childhood obesity at the core is absolutely a number one priority in our healthcare, or it should be. And And so the screening tools that we have are mostly a physical exam or the children or the parents themselves noticing a difference in their shape, right?
Mhm.
So what SRS, such as the Scoliosis Research Society, their recommendations for screening are twice in girls around year 10 and year 12, and once in boys near 12. So because what we know in our growth spurts is that girls will oftentimes either be precocious and get their periods early, or they might get them late. And so that's why we'll screen them twice. So to make sure that they're not on the early or late cycle. And boys will generally catch them before puberty, which is around 12. So as far as our children who might not have as visible of a curve, and we talk a little bit about this in our journal clubs that we do together, curves are generally only visible when the spine rotates, and that's why we see the rib hump. And so that might take a little bit better eyes as far as being able to assess that in some of our children. And that might say for one of the pediatricians, if they're just not sure, it might be worth a visit to someone like me or someone like you, who might have a better eye for that, who have a better trained eye to assess for leg length inequalities, which is a really common misdiagnosis for scoliosis. Is in fact they have a compensatory curve. Or perhaps they're just not getting them to stand up straight because they're a little bit shy about their figure, right? And so maybe there's a way to kind of coach them into allowing us to screen them a little bit better if there's a little bit better trained eye. Sometimes in those children, though, it is access that's an issue, right? And so sometimes there isn't accessible pediatrician to go annually. And so perhaps we're missing it just because of that reason. So working with the schools and working with our trained professionals like you and I to be able to help those patients get screened appropriately.
Gotcha. Yeah. And it's definitely important, if it is like a question mark of like, oh, maybe it could be scoliosis, maybe it couldn't, it doesn't hurt to, send to a specialist who looks at backs all day long, and who can say, oh, this might warrant an x-ray, as the next step. If anything, it won't hurt. And you can catch something a little bit earlier compared to waiting and seeing and catching it a little bit later, right?
Right.
Perfect.
Some of my most fun referrals are the kids who are told they have scoliosis when in fact they are pin straight. And I get to, just say, no, they were wrong. Well, how come it looks a little bit like this? I'm like, no, that's not scoliosis. They're like, oh, phew, right? Goodness, because they read, once they get that diagnosis, they Google and they see this laundry list of information. And so even then it's, sometimes a real reassurance and a breather.
Oh, for sure. Yeah. And it's not the worst thing to get those patients walking in your door, right? You just send them out, say, you're good to go.
You're okay. Promise. Go live your life. Be a good
Right.
kid. Listen to mom.
There you go. That's good advice as well. Listen to mom and dad for sure. Okay, so last question, also kind of about parents. We've talked about screening, we've talked about bracing, we've talked about conservative treatment. Let's talk about surgery, because surgery is warranted sometimes for certain curves, certain children with scoliosis, depending on, how they present. And a lot of parents think this is the end of the world. My kid's going to have surgery. They're never going to be able to do the things they want to do. They're never going to be able to play sports, things like that. Can you share a little bit about, the outcomes after surgery and something that will kind of comfort them, when their child is waiting to get surgery?
So my caveat to this question is everyone's different, right? And the curves are different. So some curves require bigger fusions. Some curves can require smaller fusions, and that takes, again, training and expertise to identify which levels need to be fused. And that in and of itself is controversial, and we're still learning. And so while there are tons of children who have scoliosis surgery and are completely normal afterwards, There are some that lose motion, and we again try to fuse as little bones as we can to achieve the outcome. And the outcome is to make them straighter, obviously, but also to halt the progression of the curvature. That's a big deal. So if we don't sometimes fuse or do surgery on curves that are of a range that are large enough, then that can progress into a way that might cause more issues inside. And so from a parental reassurance perspective is we do everything we can not to do it. We're not trying to cause issues for your children in the long run, but we're trying to help save them from other issues. And so while there are many children who have large curves who don't have surgery, I'm not sure that's typically the right answer. And so we are trying to do as much as we can to keep them as flexible as we can, as long as we can. What we end up doing is treating those children with surgery who need it. There are some children who want it, which we would, ask that you speak with your children about how they feel about their appearance. Some curves are teetering on that border of surgery versus no surgery. But there are many children who don't like the way they look. They don't like the appearance of the ribs that are sticking out on the back. They don't like the appearance of their uneven shoulders or their waist. And so that can be a very strong indicator to fix a borderline curve. And so we try to have that conversation with our children as well as with our parents to make sure that we're doing it for the right reasons. The beauty of some of the literature we've done and the research we're doing is that some of our more highly specialized surgeons in our tertiary centers, like our children's hospitals, work with a multidisciplinary team and are doing something called tethering, which is a newer procedure that's done within the chest or within the abdomen to help, again, save motion levels. And so your child may be a candidate for that too. And so we've got options. We're trying the best we can to be as conservative as we can. And if we have to do a fusion of your child's curve, we're doing it hopefully for the right reasons, as less levels as possible. Some of my success stories include 14-year-old who was skateboarding again afterwards without any pain. There's a boy playing in the marching band carrying the tuba of all things, so extra large instrument. We did just see on the news, which is pretty cool, highlighting scoliosis. There is a collegiate basketball player who's been highlighted for having scoliosis surgery. And so we are all over the place with children back to sport, back to life, horseback riding, swimming, doing most everything they'd like to do. And so it's not something that we should be afraid of. It certainly can be a scary feature in our life when we're telling you that that's a requirement, and we do what we can to help reassure you that we're going to take the best care of your children while they're in our hands, and do what we have to do to help make their life better.
Great. Yeah. So the goal is, whether it's conservative treatment or surgery, your child still has the opportunity to, have goals and reach them, whatever route of treatment is coming their way, basically. Awesome. So very last question. Is there anything else you'd like to share on the podcast? Our audience is mostly parents of kids with scoliosis. Anything else you'd like to share that I didn't ask you about?
Please get your kids active. So
yeah, I love that.
What?
Yeah, I love that. That's a huge thing.
So get your kids active, right? We've with COVID and the pandemic, we've kind of taken away some of our outside activities or indoor activities. Please utilize your resources. Get your kids outside, get them to be active, work on core strength, yoga, Pilates, swimming, anything that they can do to promote good posture, core strength, keep their legs nice and limber, help them just be a kid, right? We even during bracing or, before and after surgery, we want them to be active. We want them to be participating in sport. It's certainly going to be helpful for their joints, for their growth. for post-operative, if they need to have surgery. We want them to be as strong as they can, as flexible as they can, and as happy as they can. And so I think, my biggest thing is, make sure they get their calcium and their vitamin D for their bone growth, and they stay super active for their joints and their muscles, please.
Awesome. Yes. So really great things for overall health and also for the spine specifically. Well, great, Dr. Matteini. Thank you so much for being on here. You're clearly passionate about what you do, and you're an expert in the field. So thank you again for being here, and thank you to everybody for listening. Lauren, if somebody wants to contact you, how can they connect with you?
So I work for Fox Valley Orthopedics, so you can look at our site, fvortho.com. My site is there. So that would be the best way to find us. We're out in the Chicago suburbs. And so if there's any of your children who'd like to be seen, that would be the best place. So again, our website is www.f for Fox, V for Valley, ortho.com, fvortho.com.
Awesome. And I will throw that in the show notes so you guys can just click on it and it will be easy for you all.
That would be super.
And then you can connect with Dr. Matteini that way. Well, thank you so much again, and we will see you all on the next episode. Have a good one.
Thanks for listening to the Schroth Boss Podcast.
Want more info on scoliosis and the Schroth method?
Join our free Facebook group or connect with us at schrothboss.com.
See you at the next episode.